Good afternoon, everybody. I want to start by saying thank you very much to Diana and everyone else for the kind invitation to be here. I speak a lot on PANDAS, clinical manifestation, and impact on parents and families, but this is the first time that I'm actually able to present some original data, so I'm excited to be here for that. A little bit more about me. I'm an allergist, immunologist, pediatric and adult, and I'm also an internist, and I'm also pediatric and adult integrative medicine, so I may have a little bit of a different approach to PANDAS than some other providers. And I like to tell the story of why I got involved with PANDAS because, you know, it's a big deal to be involved with PANDAS. And so I was in a busy private allergy practice, giving allergy shots and doing what allergists do, but I had this need to continue to be an immunologist. And so I actually changed practices, and an OBGYN friend of mine called me one day and said, this was while I was still at the old practice, and said, would you take care of my child? I think he has PANDAS. And I said, no, I won't, because that's not a real disease. Everyone knows that's a made-up disease. What is it anyway? We don't know what that is, because I was in a group of doctors who didn't believe in it. And she said, please, Maeve, please, I'm begging you, just see him, and then if you want to say no, I'll accept your answer. So I read a lot, I did a lot of research, I made a lot of calls. I didn't know anything about it. I'm a very humble person, I'm also a very honest person. I knew nothing about this disease, but I said, okay, I'll see him and I won't charge you if I can't help you. I saw her son and I was devastated by what I saw and what I heard. It hit me from a professional level as well as a personal level when I saw videos of her child prior to being impacted by the strep infection that devastated his life. So I said, well, I'm an immunologist. I know how to write IVIG. I got this. All right, I'm going to do it. Let's try this. I, again, used my research, used colleagues, and we gave him IVIG, and he got better after 4 months. The next part of the story is that his brother came in with similar symptoms. Not as severe. He was moderate. We treated him. He got better. And then the daughter came in and she had mild symptoms, and the mom said, well, I don't want to do IVIG because of side effects, so we did antibiotics. So that was the beginning of why I got involved with PANDAS, PANS. So just on a personal note, that's why I treat this disease. Sometimes parents will come in and say, why do you treat this disease? And I say, because there's a lot of doctors out there who won't. And we don't always see success, as many of you in the room know, but when we do, it's certainly wonderful. Okay, the other thing I want to just let you know is this is a scientific presentation, but I did sort of want to bring it down to the level. I knew that this was mostly parents in the audience today, but let's get to the data. Just a few disclosures. I don't have any other than my research institute. I own it and I'm the medical director of it. Octa Pharma provided honorary and expenses as well as funding our research, and Molecular was generous in giving us the Cunningham panel. So study background, everyone is familiar with the definition of PANDAS, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. And I know one of the hot topics right now is that really the best and most appropriate name? We know that there's a relationship between the post-infectious response and the sudden onset of neurologic symptoms. This exists, and it suggests a form of post-infectious autoimmunity through a form of molecular mimicry. As a result of our studies and observations, we identified a number of common immune defects and hypothesized that an immune memory defect is the underlying mechanism leading to PANS. So the study design, we wanted to determine the effect of 6 infusions of IVIG in children with refractory PANS. So we evaluated 5 different categories: laboratory studies, clinical observation, validated psychometric measurements, parental assessment, and independent psychiatric and psychological assessment. And the figure over to the right is just to remind all that when we're talking about the immune system, there's a lot that goes into it. There's good and bad, allergy, immune-related disease, and autoimmune disease, and that this can be on a continuum and can develop over one's life. So the proposed hypothesis for PANS and PANDAS is very complex, as many of you know. Is there a genetic component? I know that many of you have, like the story I told, we had 3 siblings in one family who suffered from this disease. We often see some mild symptoms of OCD and tics in parents of patients who present with PANDAS and PANS. What about food and other things that we ingest in our body? Exposure to environmental toxins, allergens, other things. Chemicals, things we use to clean our homes, and chemicals I would also include in that, drugs and the effect of those on the immune system. The infection, we once thought it was just strep. We now know that strep is one of the main triggers of this, but there's also HSV, herpes simplex virus, Epstein-Barr virus, parvovirus, Lyme, Bartonella, Mycoplasma, and a host of other infections that we are learning more and more about every day that can trigger this disease. So when you have all of those factors in play, this can lead to the development of atopy or allergy, which is part of course, what I do every day, stimulating the allergic antibody, IgE, mast cells, and other cells, and on the other side, stimulating the immune system to either act well to protect us or act in a deleterious fashion, which we see in PANDAS. This can involve toll-like receptors, complement, B cells, and T cells. And we know that any sort of dysregulation amongst those can lead to the brain inflammation that we see in PANDAS PANS. We have some neuroimmune markers, the Cunningham panel all of you are familiar with, as well as neural zoomer, which I'll get into more in a moment. And it's known and has been proposed that IVIG modulation can quell some of that brain inflammation in certain subset of population of PANDAS patients. So the study overview and schematic is shown here. Again, the objective was to evaluate the benefit of Octagam 5%, Octagam IVIG 5%, in subjects with refractory PANS. The participants were male and female children aged 4 to 16 years with a diagnosis of PANS by a PANS specialist. We had a multi-site open-label pilot study, and again, the study drug was Octagam 5% at 1 gram per kilogram per body weight every 21 plus or minus 3 days for a total of 6 infusions. And as you can see on the bottom of the screen there was a pre-screen in patients who had a diagnosis of refractory PANS by a PANS specialist. The first visit was a pre-screen phone call with parents. And then visit 0, we had a 4-week visit time between visit 0 and visit 1 where we did screening of these patients to see if they would be appropriate for the study. The treatment phase went on for 6 visits of the infusions, and there was a 3-week time span between each infusion, so it was a total of 18 weeks. Post-treatment at 8 was 8 weeks, and that consisted of the final infusion, visit 7 and visit 8, where we did some post-analysis of the patients and got the data which I'm about to present to you. We let 24 weeks pass after that and then had a final visit 9 to assess patients after they were no longer receiving the infusions and to see if they had a long-lasting effect or if patients had an increase in their symptoms. This is a new study that has been accepted to the American Academy of Pediatrics. I'll be presenting that in New Orleans. So the study efficacy endpoints included changes in psychological evaluation scores from baseline to visits 7, 8, and 9. And what we used were several different measures, including the Pediatric Acute Neuropsychiatric Symptom Scale phone interview score, the Children's Yale Brown Obsessive-compulsive scale, which I will now refer to as the CY-BOCS, the Yale Global Tic Severity Scale, the Anxiety Disorders Interview Schedule for DSM-4, the Clinical Global Impression, Parent-Rated Symptom Survey, Parent and Patient Artifacts, which were various, and then we also looked at changes in functional toll-like receptors and brain autoimmunity. One thing you may be asking yourself is why did they use so many different psychological parameters? Because we wanted to make sure that we were going to have robust data, and we wanted to see if across all of these validated questionnaires, would the data hold up? So who participated in this study? Again, refractory PANS. There were 21 patients, 7 at each site. The mean age was 10.86 years. There were more boys than girls, 62%, and the majority of the patients were white. Vital signs were within normal ranges throughout the study. Octagam, again, 5% dosed at 1 gram per kilogram, and I'm repeating that again and again because it's important, and I know that we've had a lot of different dosings discussed at this meeting. The mean follow-up time from visit 0 to visit 8 was 186 days, plus or minus 13 days. And the late follow-up, visit 9, which was 24 weeks after the final visit 8, was 24 to 46 weeks after the last IVIG infusion. And this was implemented to gather additional data on durability of response. Not everyone has come for that visit 9 yet, and the reason for that is actually good. It's because they have had some durability of response, so they're feeling well. Patients don't come back usually when they're doing well. So looking at the baseline characteristics, and I'm using my hypothesis slide that I showed earlier, but in this particular study, 52.38% of patients had one of the infections listed above. 48% developed some sort of, or displayed some sort of atopy or allergy, whether it was seasonal or food or drug allergy. 86% had immune system dysregulation, but 100% of patients had abnormalities in the Cunningham panel. 100%. I know many in the audience are familiar again, but I like to bring my audience all on the same playing field so we can have a conversation that we all understand. The Cunningham panel, again, is Molecular Labs. It provides laboratory results that assist physicians in diagnosing infection-induced autoimmune neuropsychiatric disorders by measuring the circulating antibodies directed against antigens that are concentrated in the brain. You all are very familiar with these. It measures the ability of these and other autoantibodies to increase the activity of CAMK2 enzyme that upregulates those neurotransmitters in the brain as well as others. The neural zoomer you may not be as familiar with. This is provided by Vibrant Wellness. This is designed to assess an individual's reactivity to 48 different neurologic antigens, which may have connections to a variety of neurologically related diseases, not only PANDAS and PANS, but in comprehensive compilation of multiple research studies which have used these autoantibodies from the neural zoomer. They have been associated with many neurological diseases, including early risk detection of Alzheimer's disease. So the brain, as we all know, is a very complicated part of us. So looking at brain autoimmunity, looking to the left of the screen, you can see of the 21 patients, again, as I mentioned, 100% of patients had out-of-range Cunningham panel results. The light purple indicates elevation, the dark purple indicating borderline. We considered all of those to be positive, and I'm showing here the antitubulin and CAM kinase 2. And when looking to the right of the screen, this is the neural zoomer panel screening, and you can see that 71.4%, or 15 of the 21 patients, had abnormalities in antitubulin, antineuron, and anti-Purkinje. So now we're going to get to the results. So because I kind of vomited all of those different surveys, and you're like, what is she talking about? I'm not familiar with all of those. I wanted to give you a little brief summary of what those surveys consist of. So the parent-rated symptom survey is a questionnaire directed and specific for PANS with 58 questions related to symptoms. And the symptoms are graded from 0 to 4, with 4 being extreme. And this assessment is unique in that it was conducted at every infusion throughout the treatment period, so longitudinal progress could be observed. And as you can see here, the symptom scores decreased over time, being highest with infusion 1 and going down all the way through infusion 6 in a nice longitudinal pattern, going from 51.71 to a score of 27.23. And the results indicate significant reductions in symptoms beginning at infusion 3 through infusion 6 compared to treatment initiation at infusion 1. And again, these outcomes are unique and compelling. Unlike other assessments that only occurred at baseline and visits 7, 8, and 9, these assessments show steady improvement from infusion 1 to infusion 6. It's just a nice, clean graph. So the CY-BOCS, informally called the CY-BOCS or the Yale Brown assessment, this rates the severity and type of symptoms per OCD, the characteristics of obsessions, compulsions, thoughts, and behaviors. And again, it's on a scale of 0 to 4, with 4 being extreme. This is patient self-report, but there is clinical judgment that is required, and it is a very comprehensive measure of OCD. So if you look here, you can see that the CY-BOCS scale, looking on the y-axis and the x-axis showing the visits, you can see a nice drop in this as well. I won't read the percentages to you because, again, in the interest of time, but you can see from visit 7 to visit 9, the percent change was 54 down to 38, and the average change was -12 to -3.58. And these were statistically significant reductions. So the Yale YGTSS, informally called the Tick Symptoms Survey, widely used and helps quantify ticks and put them into the categories that they belong in. It is a clinician-rated, semi-structured interview. It's a systemic inquiry of symptoms for the preceding week, and it talks about also current motor and phonic tics rated separately. And the rating is based on the number, frequency, intensity, complexity, and interference. And as you can see here, that the YGTSS score shows statistically significant decreases at visit 7 and visit 8. And at visit 9, with late follow-up, as would be expected, you see an increase. So again, looking from visit 7 to visit 9, minus 54.1% to positive 51.66%, and the numerical change from visit 7 to 9, minus 19.9 to a positive 7.79. Looking at the severity of illness, or CGI, this is comparing pre-treatment ratings of severity with ratings of improvement after start of therapy. The rater provides global impressions of severity, global improvement, efficacy index, and therapeutic effect. 2 items are rated on a 1 to 7 scale, normal to, again, extreme. 4 items are rated on a 2x2 grid, which is efficacy by the therapeutic effect. And you can see here the scale was from 1 normal to 7 extreme, and the change in mean scale scores at baseline versus visits 7, 8, and 9 were statistically significant. So looking at the ADIS, which also yields the DSM diagnosis, the anxiety disorder schedule, informally referred to as the ADIS. There's a DSM-4 interview, comprehensive and methodical, helps diagnosing child's emotional disorders where anxiety is the prominent component. The manual includes a feeling visual scale, a parent interview schedule including 19 different areas, child interview schedule including 12 different areas, and problem behavior diagnoses over OCD, school refusal, separation anxiety, social phobia, specific phobia, panic disorder, agoraphobia, PTSD, ADHD, inattentive type, hyperactive type, and combined type. So again, we see a lot of things here that we see symptoms of a lot of these in our PANS and PANDAS patients. And again, the child interview questions are sensitive for their age, and that's important because you're not going to ask a 5-year-old the same thing you may ask a 15-year-old. Look at the marked drop there between baseline and visit 7. This data displays the subset of patients with a diagnosis for OCD at baseline, of which there were 16 of the 21 patients. At visit 7, only 4 patients of the original 16 had a diagnosis of OCD. At visit 9, only 1 patient out of 12, those with the data that we have at late follow-up, had a diagnosis of OCD. Specifically OCD, not PANS, PANDAS. So looking at the phone screen, OCD and neuropsychiatric symptoms scored from 0 absent to 5 this time, indicating extreme. And the OCD symptoms scoring is 5 times the worst of the OCD symptoms of 0 to 25. We all know symptoms of OCD, intrusive and persistent obsessional worries about germs, repeat hand washing, restricting food, anorexia, intrusive worries about things. I think that yesterday we heard about the yellow house from our infectious disease colleague. If we don't drive by the yellow house, something bad will happen. Hoarding and other behaviors that we are all familiar with, and unfortunately, PANS and PANDAS patients suffer so much, and families as well. So the neuropsychiatric symptoms of the phone screen is the sum of the 5 of the below 7 worst neuropsychiatric domains from 0 to 25. Anxiety symptoms, emotional lability or depression, irritability or aggressive behavior, behavioral regression, learning cognitive symptoms, changes there, sensory symptoms, visual, motor, urinary symptoms, sleep disturbances, and visual changes, and of course the eye dilatation. So looking here, OCD and other neuropsychiatric symptoms significantly decreased from baseline to visits 7, 8, and 9. This was statistically significant, and you can see the mean score versus the visit number. And again, the light purple and then the dark purple, meaning OCD for the light purple, and dark purple indicating the total score. Now looking at the biomarker data, toll-like receptors, again, some are familiar, some are not, to bring us all together. The innate immune response in the central nervous system is implicated as both beneficial and detrimental to health. And toll-like receptors have been implicated as being that. Sometimes they're helpful, sometimes they're not. They are integral to the process. Integral to this process are microglia, which of course are the resident immune cells of the CNS, and they express a wide variety of pattern recognition receptors, such as toll-like receptors, that detect changes in the neural environment, including pathogens. Toll-like receptors are very, very, very integral to the initiation of the immune response to microbial pathogens. In addition to their well-appreciated roles in initiating inflammatory responses to the microbial pathogens, recent evidence has implicated TLRs in CNS cellular repair. The current evidence to date suggests that toll-like receptor-mediated responses can exert either beneficial or detrimental effects, as I said, but it depends on the strength and the timing of the activating signal. A lot more to learn about these. But in this particular study, looking at the statistical overview, the mean pre-treatment levels in toll-like receptors was 131.07, and the mean post-treatment levels was 313.49, with a p-value, again, of less than 0.001. There was a mean increase in toll-like receptor levels of 182.43. So looking at the right side, we see that toll-like receptors are very important in infection and inflammation, but they may also be very important in immunomodulation. Quickly, I want to talk about the patients that participated in the study, because if it weren't for them, this study never would have happened, and the parents that were so dedicated. You all have seen handwriting examples that have been published before. This is actually one that was from one of our patients in the study. The pre-treatment drawing, draw self and others. And you see sort of an angry rabbit-looking type picture. And when you look over to the right, this one gets me a little bit because it's draw self, and others. And you see a happy patient with a happy other person, and it looks like they might be getting an infusion, and they look happy. So I kind of like this picture a lot, because I don't like that angry rabbit-looking thing. This is a parent narrative sample, and this was at visit 7. So during the parent portion, his mother said that it feels like my son is normal. She related that before the infusions, her son was defiant, absent-minded, angry, inflexible, and hated going to school. He did not want to do his homework. He suffered from a depressed mood. His appetite was greatly diminished, and he restricted the things he would eat. He did not want to write. He was obsessed with girls' anatomy. He feared that his words would physically hurt someone. After the first infusion in mid-April, his night terrors went away. His mother reported that between the second and third infusion, he began writing again. Between the third and fourth infusion, his mood lightened and there were no angry outbursts. His relationship with everyone improved and he was more cooperative, and between the fourth, fifth, and sixth infusions, she noted a marked difference in her son's attitude and focus. She said that he had been much happier, still a picky eater, but trying new foods without as much resistance. At times, he still counts with his fingers and taps his legs, but he's become very interested in online games and can still become a little anxious when he's away from the games. When his mother and father set limits on his playing time, he has been more relaxed and less defiant about it. He is careful to take his medicines on his own. The medications include Augmentin, clindamycin, Zyrtec, multivitamins, fish oil, a probiotic 2 times a week, melatonin, and Benadryl at night. You can imagine the integrative medicine doctor might have been the one that was this person's doctor with all of those supplements. Visit 8, another patient. The mother stated she noticed little significant changes in her son's behaviors until the 4th and 3rd infusion. Almost gave up, actually, after the 2nd infusion. Just said, this isn't working. Why am I doing this? I said, let's keep going, keep going. Up until the 3rd and 4th ones, argumentative, angry, would not eat, went to the bathroom often. In between the 3rd and 4th infusions, he was less angry and had less intense rages. He started to eat more food. During the 4th and 5th infusion, she was delighted to hear him laughing and singing to himself, the boy she remembered before he got sick. Since the 5th infusion, he is more easygoing, has no more rages, no more outbursts, more adventurous and eating lots of different kinds of food. He still likes to argue with her at times, but who doesn't? I have an 8-year-old son who loves to argue with me all the time. Thank God he doesn't have PANDAS or PANS, but I think this is just him going back to his normal, maybe cantankerous self. She reported he is presently taking B12, probiotics, multivitamin, GI Fortify, and azithromycin, and he does take Concerta for ADHD. And the reason I wanted to include all of the things that they're still doing, even though they are better, is because there's a multidisciplinary approach for this disease, and it's also heterogeneous, as we know, but the improvement is obvious, and this is from the parent's perspective. In conclusion, in PANS patients, all psychological endpoints studied exhibited statistically significant decreases following 6 cycles of IVIG, octagam 5%, 1 gram per kilogram. PANS is an autoimmune disease. We all know that. Innate immunity and the complement system may play a role in the pathogenesis of PANS, and statistically significant upregulation of toll-like receptors in response to IVIG could be implicated in the CNS inflammation and the symptoms. Patients with PANS can benefit from a 6-cycle course of IVIG, and provisional late data demonstrate durability of the positive impact of this IVIG treatment. I have 2 more seconds to just say, I know we've been talking about what is the right name, what are we calling this? We're seeing adults that are presenting with it, whether they started as kids or whether it's a new onset. So what are we doing? Is it PANDAS? Is it PANS? PITANS? Are we going to call it this long name and include the basal ganglion? It just goes on and on and on. So I was not asked to give my idea, but I'm going to share it with you anyway. What the heck? This is a dire disease, right? Does anybody in the room say this is not a dire situation? So, dysregulated immune response encephalopathies. You don't have to pick it, but I kind of like it. The only other thing I would like to say is that people may not always remember everything you said, but they will remember how you made them feel. And I hope that this study gives you guys some hope, because it certainly does give me hope.